Hey guys, it's Olivia. Welcome back to your endocrine chapter. In this chapter, we'll be discussing SIADH, or the syndrome of inappropriate antidiuretic hormone secretion. Antidiuretic hormone is also called vasopressin, so just keep that in mind as well. And this is a syndrome that's highly likely to come up on your board's test as a way for test writers to test you on kidney pathophysiology, as well as your understanding of the role of ADH and these hormonal control systems that control the amount of sodium and water being reabsorbed in the kidney. So before we discuss the syndrome of inappropriate antidiuretic hormone secretion, let's first discuss the role of antidiuretic hormone. So antidiuretic hormone is going to be produced by the hypothalamus. That's why it's in the hypothalamus chapter. And it is then going to be stored in the posterior pituitary. So produced by the hypothalamus, but stored in the posterior pituitary. When it's released from the posterior pituitary, it is going to travel to the distal convoluted tubule. So the distal convoluted tubule over here in your nephron is where it's going to exert its effects. It is going to insert a lot of aquaporins into that membrane, thereby increasing water reabsorption. Water comes out of the urine and into the bloodstream. When it goes into the bloodstream, we get what's called hemodilution, and that's exactly what it sounds like. Heme, blood, dilution, more dilute. And that makes sense, right? Because we're pulling water out of the urine, and that water is going back into the blood. If there's more water in the blood, but the same amount of solute, if you're adding more water to the Gatorade, it becomes more dilute. So that's the hemodilution that we'll see with antidiuretic hormone. And this is a mechanism by which we can normally concentrate our urine. It's very helpful if you're dehydrated. But in the syndrome of inappropriate antidiuretic hormone secretion, you're not dehydrated. You shouldn't be secreting ADH. That's why it's inappropriate. So when you have this inappropriate secretion of antidiuretic hormone, there's too much, then we're going to get what you call a euvolemic hyponatremia. So first, let's just talk about the hyponatremia part. Because we have pulled all this water out of the urine and back into the blood, and we have this hemodilution, everything in your blood is being diluted. And one of the things that's diluted is the sodium. And that's going to be the hyponatremia part. But if you understand how antidiuretic hormone is working and you understand some simple effects of blood pressure, you should be saying, well, Olivia, we just pulled all of this water that shouldn't be there back into our blood. We added a ton of water. So don't we have a ton more volume? Why the heck are we euvolemic? Well, that is a great question, and there's a little wrinkle here that's really important for you guys to be aware of, and the wrinkle is that we've had all this water reabsorption. That is going to increase our blood volume, but this increase in blood volume is actually going to lead to an increase in blood pressure, which is then going to stimulate the release of ANP and BNP. Remember, this is atrial natriuretic peptide and brain natriuretic peptide, and their job is to shut off RAS. So because we're shutting off RAS in this situation, there's kind of a counterbalance of all this water that's being reabsorbed. So RAS is off, so we're not saving any of our sodium. We're excreting a lot of our sodium, and that's going to actually maintain a euvolemic state. That's why we're in the euvolemic hyponatremia category over here. Even though we are absorbing an inappropriate amount of water, the RAS is kind of helping us maintain this fluid balance and this blood pressure overall. So it's a little bit of a complicated mechanism, but I think it is important to understand why we have a euvolemic instead of a hypervolemic hyponatremia here. So what causes inappropriate antidiuretic hormone secretion? Well, there are several causes, including an ectopic cause. And by this, I just mean that antidiuretic hormone isn't being secreted from the posterior pituitary where it's normally stored. It is being secreted ectopically from another source. And that other source is going to be small cell lung cancer. So small cell lung cancer, whenever you have a patient that presents with this mass in their lung, and then they also have all the symptoms of SIADH, is going to be a great bet that they have syndrome of inappropriate antidiuretic hormone secretion. Other things that might cause inappropriate antidiuretic hormone secretion are CNS disorders or head trauma. That makes sense. If you have damage either to the hypothalamus that is creating ADH, or you have damage to the posterior pituitary where it's going to be stored, that could release a ton of ADH into secretion and cause your syndrome of inappropriate antidiuretic hormone secretion. Similarly, certain drugs can cause SIADH, most notably for your boards. I think it's important to be aware of cyclophosphamide, so that chemotherapy agent that we can use. SSRIs, so these drugs we can use to treat things like anxiety or depression or OCD. Those can definitely cause the syndrome of inappropriate antidiuretic hormone, as well as carbamazepine, which is an anti-seizure drug. It can cause it as well. Okay, so let's say you have SIADH. How is that going to present? Well, the presentation is going to be all the clinical features of hyponatremia. Remember, the main problem here is that we have diluted our blood and have functional hyponatremia. Well, this is going to present with nausea, vomiting, lethargy, confusion, altered mental status, seizures. So if you see someone coming in and they're really obtunded, they're kind of acting weird, they are very nauseous, maybe they've thrown up a couple times, those are great clues that we might be thinking of a hyponatremia. Because it is a euvolemic hyponatremia, though, as we discussed earlier with that RAS system that is often going to be balancing our volume status here, we're not going to see any of the symptoms that we would see with either hypovolemic hyponatremia. So if we had hypovolemic hyponatremia, we might see hypotension or tachycardia as we try to keep up our blood pressure when we have too little volume. Similarly, we're also not going to see any of the symptoms of hypervolemic hyponatremia, which would be like edema or volume overload. Remember, because this is a euvolemic state, so we don't have any volume problems, no hypotension, tachycardia, or edema. And this is going to lead us nicely into how we diagnose SIADH. So first, remember, we have a hypotonic hyponatremia. Hypotonic hyponatremia over here means that we have a serum osmolality that is less than 280 milliosmoles. So we are hypotonic here. Similarly, this is a euvolemic hyponatremia. So euvolemic, as we discussed earlier, we are going to have no changes in our volume status. We are going to have no hypotension, tachycardia, or edema. So that already is going to put you into the right neighborhood, which over here is our euvolemic hyponatremia on your hyponatremia chart. But what are going to be some other helpful hints and lab values that can help you diagnose SIADH and distinguish it from other causes of euvolemic hyponatremia? Well, before we dive into that, I think first it's helpful to go through a quick review of osmolality. What is osmolality? Well, osmolality is milliosmoles per kilogram. So it's milliosmoles of solute per kilogram of solution. So it's basically how much stuff is floating in the water. And if we have more stuff floating in our water, that means that we are going to have a concentrated solution. So high osmolality equals concentrated solution. So I think this can be kind of confusing. I just always like to remember that osmolality equals concentration. So if we have higher osmolality, higher concentration, lower osmolality, lower concentration. And that's the way that I keep this straight in my head. This is going to be important when we're discussing SIADH because in SIADH, we are going to have increased urine osmolality. That should make sense to you, right? We pulled all that water out of the urine, so the urine is higher concentration, higher osmolality, as well as decreased serum osmolality. So again, because we pulled all of that water into our blood is more dilute, so we have decreased serum osmolality, and that is that hemodilution that we discussed earlier. So those are two of the lab values that you might see in SIADH. Another important one is that because we discussed our RAS system being off, remember our RAS system is off because we have that increased volume stimulating ANP and BNP release, the RAS system being off means that we're going to have a urine sodium that is greater than 30. Urine sodium greater than 30 is a great proxy for the RAS system being off when things are working physiologically normal. Finally, this might be an obvious one, but we are going to have increased serum ADH. It is the syndrome of inappropriate ADH secretion, so we are going to have an inappropriately high level of ADH in our serum. And taken all together, these lab values paint kind of a weird picture, right? Because we have increased serum ADH, but we have decreased serum osmolality. So we know we have dilute blood. When we have dilute blood, we should have really dilute urine because we're trying to pee out that extra water. But if you have that dilute blood, very high ADH, that's kind of weird. That's not right. So if you ever see blood that's super dilute, but our patient is still making concentrated urine and there's high ADH, great bet that we're talking about the syndrome of inappropriate antidiuretic hormone secretion, because this, of course, is an inappropriate response to a hemodilute state. Now that we've diagnosed our patient with SIADH, how are we going to treat them? Well, we can treat them with fluid restriction and IV hypertonic saline. That makes sense. If they are holding on to all of the water that we give them, we should give them less water because they won't be able to put it right in their blood and keep diluting it. Similarly, with IV hypertonic saline, you're going to want to be repleting that salt that they have diluted in their blood. So hypertonic saline is about 3%. But why would we not give them normal saline? Normal saline has salt in it. If we just want to give them salt, why can't we just give them normal saline? Well, normal saline actually is going to be very bad for these patients. And that's because if you give them normal saline and your body has secreted all of this antidiuretic hormone inappropriately, essentially what's going to happen is your body is going to hold on to all of the water that's in that saline, but because our urine sodium is still higher than 30 and our RAS is off to maintain an appropriate volume balance, you're going to pee all that sodium right out. So that's why we don't give these patients normal saline, because if you give it to them, essentially you're making the problem worse. They're going to pee out all that sodium that was in the normal saline because there's not enough in there to override this RAS system's work. And then they're going to reabsorb all the water. So they're going to make their blood more dilute. And essentially, this is going to be the opposite of what we want. It's going to be making the problem worse. And that is why when you have SIADH, hypertonic saline is the way to go. Hypertonic saline is going to be your friend here and on test day. Additionally, when we treat SIADH, we do have some pharmacologic agents available. These are going to be our Vaptans. So our Vaptans, Conivaptan, Tolvaptan, you get the idea. These are going to be our ADH antagonists. So these are going to go to the receptor where ADH is working, and they are going to make sure that ADH cannot do its job. Finally, there's demeclocycline, which actually can induce diabetes insipidus. So I always kind of think of it as the opposite of SIADH, but demeclocycline can also be used to treat SIADH as well. One final note on the treatment of SIADH. So we have these patients come in, they're hyponatremic, they have this risk for lethargy, confusion, seizures. That's really dangerous. They also have risk for arrhythmia when they are hyponatremic. So why don't we want to correct their hyponatremia as fast as possible? Well, when we do overly rapid correction of hyponatremia, it's actually quite dangerous. And that is because it can lead to something called osmotic demyelination syndrome. And in osmotic demyelination syndrome, what happens is we see this rapid shrinking of our neurons that leads to demyelination, and demyelination of our neurons, of course, causes nervous problems like dysphagia, quadriparesis, lethargy, coma, seizures, confusion. And I think that the classic presentation for osmotic demyelination syndrome is kind of this locked-in syndrome where you can register what's going on around you, you know what's happening, but you have lost all motor function completely. You're essentially paralyzed, but you are mentally there. And that is one of the most severe complications of osmotic demyelination syndrome. What happens if you correct the hyponatremia as fast as we possibly can? A little bit on the pathophysiology of this. So when you have chronic hyponatremia, your brain is going to adapt. So when you have chronic hyponatremia, there's not as much salt in circulation. So there's not as much salt holding on to the liquid that's in your blood, which means that fewer brain osmolytes are required to pull water into the brain and maintain its turgor. This means that if we correct the sodium super rapidly, and then all of a sudden the blood has much more capacity to steal water back from the brain is not prepared to be able to hold on to its own water. This leads to less resistance to shrinking because the brain's not fighting the blood as much as it should to hang on to enough water to keep itself very robust. The rapid shrinking of neurons that we see when we rapidly correct hyponatremia, and that's what's going to lead to the demyelination and all of those motor problems. So this pathophysiology is also why it is more dangerous to correct chronic hyponatremia rather than acute hyponatremia. And that's because in chronic hyponatremia, you have had more time for your brain to adapt and more time for your brain to say, I don't really need all these osmolytes. We can decrease the levels of those. And because there's more adaptation over a longer period of time with chronic hyponatremia, it's actually going to be more dangerous to correct sodium fast when you have chronic hyponatremia rather than acute hyponatremia. So a great point to keep in mind there. So we've made it to the end of this video. Let's quickly review some of the high points about SIADH. So your classic patient with SIADH, when they talk to you on a board style question, is going to be someone with either small cell lung cancer or a recent CNS trauma, or that's taking any of these medications. So if they tell you this patient has seizures, maybe they're on carbamazepine, this patient has depression, maybe they're taking an SSRI, or this patient has gone through chemotherapy recently, maybe they took cyclophosphamide. There's usually going to be some clue about one of these causes in the stem. And then they're going to say something like, patient presents with nausea, vomiting, altered mental status, and confusion. However, they don't have hypotension, they don't have tachycardia, and they don't have edema. And your brain should be going off right now that we are talking about a euvolemic hyponatremia because we have all the symptoms of hyponatremia, but it is euvolemic. And because I've given you one of these risk factors that can cause SIADH, you should already thinking about SIADH. You can then check your diagnosis with these lab findings. So if we have inappropriate antidiuretic hormone secretion, we are going to have decreased serum osmolality because of this hemodilution, but we still have this really concentrated urine. So if you see these two, you know that this is an inappropriate response, likely SIADH. Additionally, when RAS is off, our urine sodium is higher than 30. And then, of course, we have increased serum antidiuretic hormone. Once you've confirmed your diagnosis of SIADH, we're going to treat this syndrome. We can use fluid restriction hypertonic saline, and we can also use our ADH antagonists, Vaptans, as well as dimethylcycline. What we're not going to do is we're not going to overcorrect their sodium. We're not going to overcorrect their hyponatremia because we know that could cause osmotic demyelination syndrome, and we do not want to have a patient with locked-in syndrome. Great. So now you have an awesome understanding about how to diagnose and treat SIADH. Let's try a practice question. Well, they might say something like, a patient presents with nausea, vomiting, and confusion. They're not tachycardic, blood pressure is stable, medical history is unremarkable except for anxiety and depression, for which they are seeing a psychiatrist. They are given tolvaptan and their symptoms improve. What was their urine osmolality, urine sodium, and serum ADH prior to treatment? Well, in your question stem, they told you that our patient has nausea, emesis, and confusion. That could be hyponatremia. That could be a bunch of other things too. But they're not tachycardic, they don't have hypotension, and they're not edematous. Okay, so they are euvolemic. Great. Maybe we have this euvolemic hyponatremia picture here. Another clue that they gave you was they told you that this person is being treated for depression and anxiety. So they could definitely be on an SSRI, which is one of our causes for SIADH and should heighten your suspicion for this diagnosis. Finally, they told you that they treated it with tolvaptan and their symptoms improved. So right now you should be saying slam dunk, this is SIADH classic. But the question they actually asked you was, what was their urine osmolality, their urine sodium, and their serum ADH prior to treatment? So before you fixed it, what did they have? Well, first of all, we know this is SIADH, so this is going to be increased. It's inappropriate antidiuretic hormone secretion, so we're going to have inappropriately high levels of antidiuretic hormone. These other two, we're going to have to think about the pathophysiology a little bit. So with our urine osmolality, we have antidiuretic hormone that is going to be diluting our blood by saving all the water. That means that there's less water in our urine, so our urine is going to be more concentrated. We know that urine osmolality is kind of a proxy for concentration, as we talked about down here. So high urine concentration is going to mean high urine osmolality. We can also think about the urine sodium. And remember, when we talk about urine sodium, we're usually talking about, is our RAS system on or off? So if our RAS is off, we're going to have urine sodium that is greater than 30, or just more generically, a little bit on the higher end of normal. Because our RAS system is off, we are not saving our sodium, we are excreting a lot of it in our urine, and that is how you're going to answer this question. Now, I hope this video has made you a lot more confident with SIADH and answering questions about this pathology on step 1. I'll see you next time.